Cool. All right, we're going to let attendees continue to fill in. We'll probably get started here in a minute or so.
Perfect.
Oh, Josh, I meant to ask too. How was the weather down in Temecula? I was down in San Diego the last couple of days.
It's pretty hot this weekend. It's supposed to be over 100. So I actually rented a big inflatable, and all my kids. I have 4 kids, and my nieces and nephews. I don't know. Hopefully nobody will run in my office, but they're out playing in an inflatable and having fun. So.
Yeah. That's gonna be fun. Yeah, our pool in our area up in Los Angeles is open now, so we're heading to the pool later today once we get done with work, and then this weekend just try and stay cool. Yeah, it's hot. I had to carry my dog home at the end of his walk this morning, so it's getting up there. Cool. All right. Well, I think we're probably good to go ahead and get started here. So, hi everyone. This is John Hansbrough with the LBL Group. We are part of the Actuarial network, and as an employee benefits focused firm, we're helping groups understand how to use their data to better manage their healthcare, and both today and into the future. And so obviously right now with everything going on with COVID is just presenting a number of issues. It's both creating new ones as well as exposing existing issues that we've been dealing with in the industry. And so in that mind, I thought it made sense to bring Josh here to our conversation. Josh is with Axene Partners. He's an actuary. We'll get into a little bit about what exactly that means. But first, I wanted to level set a little bit about what's going on with COVID right now. So America right now has just a little bit over 3 million confirmed cases. We've been adding about 50,000 a day. And so far, it's estimated that about 135,000 people have died as a result of the novel coronavirus. So this massively disruptive virus has run headlong into a burgeoning issue in America in healthcare today, which is it's been increasingly expensive healthcare and health insurance. So employers right now are looking extremely closely at their businesses. They're trying to find expenses that they can cut, waste that they can squeeze out. And healthcare is usually, for most American businesses, a top 2 or 3 line item expense. So we thought it made sense to bring in the pro, Josh. And he's here. He's a partner and senior consulting actuary with Axene Partners. So Josh and his team, what they do is they look for trends in current and projected healthcare spending in order to better inform employers and insurers. Josh has been modeling the impact of COVID, and I'd like to introduce Josh and let him share a little bit about himself and his team. Josh?
Awesome. Well, thank you, John. I'm excited to be here. I'm excited for you guys to meet an actuary that might not be like every actuary you've met. If you've even met one, I'm sorry. I apologize for the profession and for maybe the awkward social time you had with that actuary. But I have been a consulting actuary for about 18 years now. I work with everything from small self-insured groups. I've worked with groups that are a couple people, all the way up to self-insured groups that have millions of people, over 1 million people, and then also some of the biggest health insurance companies in the world. Our company gets to work on all sides of healthcare, which is exciting because we have doctors on staff. We have actuaries, which I guess I never really defined what an actuary is if you don't know. But an actuary is essentially a math nerd, or you take about 10 years of exams and you become a certified actuary. And in recent words, you might start hearing a lot about data scientists. I think actuaries were kind of data scientists before data science existed. And actuaries are, it's a certified profession, a lot like being a lawyer, where there's exams you take, there's rules you have to follow, there's everything. But in the end, us and myself, I'm passionate about trying to help lower the cost of healthcare through learning from the data, but also in how medicine is practiced. So that's where we often get into even like what doctors do, why they do them, how often they do them, how much it costs. And today that kind of brings us to COVID. COVID has kind of thrown us all for a loop over the last many months. And we've spent quite a bit of time, analyzing COVID, trying to help with projections for COVID. And I have a presentation I'm going to show you guys today that will hopefully walk through some of what we do and what we've learned in COVID. And one thing I like to say, I was talking to John earlier, is you can watch the news, you can read all these statistics, you can find out all these things, and it's scary. But I want to be able to put out some hope that there actually is a lot of hope here, and it's probably not as bad as most of us are thinking about when it comes to the finances of healthcare. Because there was a study that came out at the beginning of COVID back in February, that said The Can you hear me? I don't hear you, John. I'm sorry.
Yes, you're back online now. We can see you. Or we
Okay,
can hear you. We can't see you just yet.
Okay, I'll put my, I don't know what happened. My video is back on. Hopefully you can hear me. And sorry for the technical difficulty.
It's all good. Hey, it's all part of the experience of working from home. It's a little bit more fun.
Exactly. So should I start my presentation? Are we good?
Yeah, I think really quick, the one thing you'd mentioned, I think right where you got caught off was you mentioned a either report or article that was released, I think back in February or March, so pretty early on to this. What was that addressing exactly?
Oh yeah, sorry. Yeah. Back in February, it was actually it was released by Covered California. There was a report that they put out that talked about a potential 40% increase in claim costs related to COVID for that, how it's going to affect 2020 claim costs. And as my presentation will show you, in what we've done and in our projections, 40% is not a reality. And the reality is actually probably a lot better than most of us are even thinking. So yeah, I look forward to sharing that with you guys.
Yeah, I think that's really good to point out because that's something that, you know, we've been hearing a little bit. I remember seeing that report and like, you know, for us at the LBL group, our jaws just dropped. We said, we're going to be showing 40% rate increases, you know, potentially at the end of the year for renewals for next year. That's crazy to think about. But as time has gone on, you know, we've been seeing news reports about how carriers, they're sitting on all this surplus because sure, there's COVID claims, but we're also not having elective procedures. There's a lot of deferred procedures. There's delayed procedures. There's procedures that just might not end up happening, right? The example, you know, we've been using is that if you're going to get your teeth cleaned every 6 months and you've missed one of those, you're not going to get your teeth cleaned twice in 1 month, right? Yep. There's some care that's just going to disappear. And so I think that's why we wanted to have this conversation, is that there's a lot of these inflating and deflating variables that are going to be affecting healthcare costs. And we just kind of want to ferret out what the end result is going to be, right? I think the last thing, Josh, I'll include before you get started is just as a reminder, this conversation is meant to be only used for educational purposes. It shouldn't be taken as advice for any specific situation. So don't go making any decisions without consulting a professional about your specific circumstance. So, you know, we had to cover this last week or 2 weeks ago at this point now for an estate planning conversation. Same thing now. Make sure that if you're going to make any changes to what you're currently doing, talk to a professional who's well aware of your current situation. So, Josh, I'll leave it to you.
Well said. Well, I'm going to share my presentation right here. Hopefully you guys are seeing it. Are you seeing a presentation?
Yep, we can see it.
Perfect. Okay. Potential impact of COVID-19 on healthcare costs. So I guess we already talked about us a little bit. I showed you, I guess here, just reminding you that in my daily life, I work with actuaries, clinicians, and IT developers. We've kind of brought those three things together so we can kind of help on every part of healthcare. Here's a quick slide. This kind of talks and shows maybe some of the people we've worked for. You see some of the biggest insurance companies. You see some of the largest employers, all the way down to, little employers. We've worked a little bit across the board. If you Google us long enough, you can actually find a front page paper story in the LA Times back before, I guess, Obamacare started. And we were part of the team that discovered a large increase in Anthem rates that many actually people talk that if that large increase wasn't found, maybe Obamacare would have never happened. And good, bad, or other, maybe you blame us, maybe you're happy with us, but next slide. So when we think about healthcare, this is one of my favorite quotes about healthcare is, in healthcare, we often move too slow until we move too fast. If you think about COVID, you can look back on it now and there's people complaining that we didn't move fast enough. There's people complaining that we moved too fast. But a lot of times we move too slow and then we overreact to what's going on and we run too fast without thinking. And you can see that when it comes to different procedures. People get really excited about a new procedure, and it's probably been around for a long time. We jump into it, we move too fast, we get excited about it, and we didn't really figure out what it really was doing or what the consequence could have been. Now, another quote, I maybe do this for my mother, but is a Simon Garfunkel quote. It says, "Slow down, you move too fast. You got to make the moment last." The reason I say this one isn't because I want COVID to continue. No, I want my kids to go back to school. I want the virus to go away. I want to sit in restaurants again and feel confident. I want all that. But I also just want us to slow down and know that COVID isn't going to end the world. Right now, I believe COVID is a big deal. COVID is not a propaganda. It's not a move by pharmaceutical companies to make a bunch of money. I believe it is a real thing. But I also think we need to slow down and really just take it one day at a time. And in the end, we will get through this. Early COVID findings, as we talked earlier, were looking really dramatic. There's a picture of a tidal wave right there. We thought that things were going to be a lot worse than they were, and they had the potential to be. I 100% believe that the interventions we did as a country lowered the curve, slowed the hospitalizations, and changed what could have happened. Yes, recently, even as of this week, we're seeing stuff spike up again. But if we would have never locked down 3 months ago, I firmly believe we'd be in a much worse position today than we are. COVID has already started affecting 2020 claim costs. And actually, while I'm saying that, it's actually affecting 2021 claim costs as well. COVID is a disruptor. It's causing changes to the way medicine is practiced. There's been more telehealth visits in the last few months than maybe in the history of the US before that. The pandemic, COVID, is going to affect both fully insured and self-insured markets very similarly. Yes, like some of the self-insured markets, some of these smaller groups may not have a COVID claim, but COVID will affect them. Large employers, large insurers, most likely it'll be hard to avoid a COVID claim, and it will affect them, but it does affect everybody. Nobody is fully insulated from it. Even looking at the economy, when business had to shut down, I don't think you can say a single business wasn't affected by COVID. Amazon probably has loved COVID. Walmart maybe loved COVID, grocery stores, but then restaurants and family businesses, everything has been affected. Hospital censuses are down, and you're hearing stories now of hospitals laying off people and pay cuts and all this. But then at the same time, you're hearing about ICUs being overrun with people and ERs packed to the brim, or you're seeing a lot of I guess, effect on our healthcare system. So today I'm going to be kind of walking through a little bit of a projection, and I'm going to try to keep it at a high level. Not everybody wants to see numbers all day long, but I want to explain enough about what the model's doing that you can gather that it's not just pulling numbers out of thin air. This model, we're basing it on the limited data that we do have. COVID doesn't have much data out there yet, but we constantly are updating the assumptions in this model and what we believe is true in the market. For this reason, we have built this model to just be flexible. The core of the model is an under 65 population, a commercial population, and we use what we call an actuarial cost model. And an actuarial cost model talks about how much things cost and how often they occur. And when we're doing this projection, we're not only adjusting what we think the cost of care is going to be, but how much care is going to be consumed. We are using paid dollars in this, and I guess it's, as the slide says, an 85% benefit value or actuarial value, which mainly is telling you that we're using a really average plan across the market. I'm not going to go too deeply in all these, but yes, as I said, we're using paid claims. One thing we're doing is we're looking at services, and what I'm going to call services is we have an allocation of elective services, and we have required services. If I have a heart attack or need a pacemaker put in, that is a required service. You need to get it done. If I wanted to go in and get my knee scoped or get even a knee replacement, might be viewed as an elective procedure. Yes, you might need it long term, but it doesn't need to be done now. One thing where COVID has really disrupted us is it's essentially shut down a lot of elective surgeries. There were months where 0 elective surgeries were happening. I like your dentist example because, yeah, that's maybe an elective surgery. I think some people are so passionate about it, maybe they feel like it's required, but it really is elective, but good preventive care. But a lot of good preventive care has also been delayed just for fear of getting sick and even just trying to create capacity for the people that are going to need it. We acuity adjusted provider costs. What does that mean? We are adjusting for how sick people are. Like when we talk about elective surgeries not happening and hospitals being maybe less busy than they were, when you're really sick, you're still going. So we've attempted to adjust this model for the people that actually are still in the market and consuming care. Most likely they are sicker people. For the whatever possible we're able to do, we are projecting COVID costs, like what we think maybe even a test costs, or what actual inpatient stay for COVID costs, being on a ventilator might cost. We're adjusting it by month. And as you've seen, when we got back to March, at the beginning of March, not much was happening. Every January, February ran like normal claims. March hit, and there was a major slowdown in claim payments and activity. April hit, got even worse. May, I would say, probably got even slower, less happening. We hit June, and I think everybody they loosened up a lot of restrictions, and things got closer back to normal. And as of even this morning, I was on a phone call with a hospital client of ours, and they're seeing in their hospital pre-COVID utilization occurring, where they're seeing back like patients, claims, things happening just like it was before. But we're also maybe right in front of another major slowdown coming. They weren't in California, they were in another part of the country that maybe isn't as affected right now. One thing that oftentimes comes up with employers is COVID copays. A lot of employers, especially in the self-funded group and market, have just eliminated any copay to do with COVID to just promote people getting tested and promote people, if you have it, to get care. So this might be the most important slide in my whole presentation. If I've already put you to sleep, look at this slide. I put 3 projections together. One that says favorable, one that says expected, and one that says moderately adverse. Keep in mind, I didn't say extremely adverse, and I didn't say extremely favorable, but if I was saying extremely adverse, maybe I would hit that 40% claim difference that we saw early on. If I would have said extremely favorable, I might have seen a 20, 30, 40% decrease. But in realistic terms of what we believe is going to happen, I would say on average, COVID, we could maybe expect somewhere around maybe a 2% increase in claims going out of this year, coming for 2020. That number, I truthfully believe it's probably somewhere between favorable and expected is the right number. So maybe like when in favorable here, I'm saying a 3% decrease in total claim costs for 2020. So how am I feeling that they're going to be a favorable, or how do I really believe claim costs could go down? Well, like we talked about, elective surgeries maybe aren't happening. There are some huge claims. Yeah, a COVID claim could be hundreds of thousands of dollars if you're in the ICU. But a lot of the costs that are going towards COVID care are actually able to be kind of covered by the lack of costs of a lot of elective care that isn't happening. Even some required care that might not be happening. So I believe in the spectrum, I believe somewhere between 3% decrease in claim costs up to a 7% increase will probably be where 2020 lies. Keep in mind, a month from now, 2 months from now, that could drastically change. And it could be, but I think this is a good average national view of what we believe is happening across the country. There are parts of the country that might see even more favorable or moderately more adverse, but in some cases, in parts of the country where maybe COVID is worse, it sounds backwards, maybe doesn't sound intuitive, they actually could see more favorable claim costs. Because as sometimes when things are worse, it might be a fear complex, but a lot of people are less likely to go consume care. I recently was on the phone with a doctor in Dallas, Texas. And he, back in February, his ER was full to capacity. People lined up down the hallways because it's a fast growing community, not enough beds. Fast forward March, April, May, he actually got about a 50% pay cut because the ERs were empty. Nobody's going to the ER. Nobody's willing to go consume care. Interesting thing about this, and we do a lot of measuring efficiency in healthcare, is maybe at that point, the ERs were probably used as they should have been. ERs were designed for life and limb threatening care, not for ear infections or boo-boos on your finger or other things. Their ER is emergency room care. It's called the emergency department. So, but it's interesting because it starts showing some of the misaligned incentives in the healthcare system a little bit, where ERs often feed hospitals and put people in hospital beds. Hospitals get scared when their ERs aren't full because they're not going to be able to fill up hospital beds. And it just becomes very confusing. It's something to think about. Maybe when we have question and answer time, we can talk a little bit more about that. But through this whole pandemic, ERs have seen a huge drop off in care. And is that good? Is that bad? It might be in the eye of the beholder. But I know that now ERs are starting to get a lot more busy, not just with COVID claims. And God bless all of our ER doctors and nurses working there, because it is frontline work and you're dealing with a lot of COVID patients. But it is an interesting part of the healthcare system right now.
Yeah, Josh, can we talk about that a little bit? So yes. I guess that's a question that, we've been wondering with regards to healthcare right now. What care out there is being deferred? Again, going back to that, like we mentioned, what's being deferred versus what was kind of unnecessary or unneeded, right? Because, someone bruises up their knee, they get, they don't need an ambulance ride. They don't need $1,000, $1,500 ER visit and all that stuff. So there's kind of a forced efficiency that's created because of that. We're not having that wasteful spending as we did before. But just a personal example close to home. I was in San Diego visiting my mom because she broke her arm last month. She was doing some gardening work. She's home, way more. So she thought, now I'm going to go get outside. I'm going to go to the garden. I'm going to do some work. Trips, falls, breaks her arm. So she did. She went to the ER. She had a visit with the doctor, and she's working through physical therapy, trying to do some of it digitally. But that was an example of care that, she needs to go to the ER one way or another. So are you seeing, though, on the flip side, that there are some things that needed to be seen in an ER setting? They needed to be addressed quickly, but they're being deferred. Have you guys seen anything like that show up in claims data yet, or other sources of data?
We actually have. It's interesting, yes. We're seeing a lot less, like low acuity ER, definitely down. Some higher acuity ER also down. And now, because of that, we have seen maybe some more higher acuity inpatient stays, like somebody that was maybe having some heart, like an AFib thing going on with their heart. They avoided going to the ER because they didn't want to get COVID, and it got worse over a few months, and then they maybe had a more extreme heart attack and they get hospitalized. We have seen some of that. Yeah, I don't know that it's the rule, maybe it's more the exception, but at the same time, we are seeing some of that where care that really needed to and probably most efficiently should have been already taken care of or started the path of care has been delayed. And one thing when we talk about healthcare is you want to do the right thing at the right time with the right people. So COVID kind of throws that off a little bit, where some of these people aren't getting the right thing done at the right time, and they're delaying it. So when you're not getting those three things, right time, right person, right care, done at the right time, it actually makes costs go up. One interesting fact in the hospital in general is about 1/3 of the care in the hospital that occurs is potentially avoidable. And when I say that, I could say the word wasted, but people get really mad at me if I say wasted. I will say potentially avoidable, where there's people that stay in the hospital longer than they need to. And it's not always the person's problem. Sometimes it's a discharge issue, like they just don't get around to discharging people. There's a lot of times people just want things, and sometimes doctors are in our society get a little scared and they want to run even more tests because they're afraid of getting sued as well. So we have a system where more care is being consumed than is probably needed. And in our case, we think about 1/3 of the cost is in inpatient could probably be avoided or lowered, either from moving it to outpatient, or it not even occurring at all, or maybe even getting somebody on the proper drugs at the proper time can help avoid costs in inpatient. And like you're saying, yeah, there's pieces of that too. Like if you're a diabetic during COVID, you might not be going to your doctor. You might be a new diabetic. I know a friend recently that found out they're diabetic, but they might not be going to their doctor. They might not get on their insulin. They might not get on their whatever drug they're on in time. And that can turn into larger claims because of the timing of their care that they're supposed to be receiving. So there's a couple examples. We are definitely seeing some of that. And thank goodness for telehealth visits. I know I had a telehealth visit, and I know my parents who are Medicare ages, they've been consuming some telehealth visits, and it's actually been great. Telehealth visits cost less. You also don't sit in a waiting room. You're able to have a visit while you're home on a couch, and you're still getting great care. And it's definitely something that I think has been a wave of the future. We were working with telehealth visits 15 years ago, actually it's about 10 or 12 years ago, trying to help a company that wanted to get in and bring this to the market, and everybody kind of laughed at them. And it's amazing how fast healthcare moves really slow until it moves too fast. COVID hit and we moved fast. I don't know that I'll say we moved too fast because the technology was already there, just people weren't adopting it. But when people noticed, like when doctors even noticed that, hey, I still want to see patients, they quickly pivoted and started doing it.
Yeah, I guess we could go down so many tangents there. One thing that does come to mind, we were seeing this, is that I believe it was Medicare expanded what they would reimburse for telehealth visits, but a requirement they had was that it couldn't just be audio. It needed to also have a video element for it to qualify as a visit for them to be reimbursed.
Yep.
So then you run into the issue. Well, some populations are going to be able to figure out how to put on a video and be able to be seen by their doctor, right? It's putting a lot of onus on the patient. Well, what if you've got someone who, for whatever reason, maybe they don't have the technology at home, right? It's gonna lead to so many issues of inequities across healthcare for different populations, for maybe their technological ability to get online, be able to get a video up and running, or what have you. So, all that stuff is going to be like it's not an unintended result, but like you said, there's just these, tendrils of results and, unintended consequences that are coming up with all these things as we're changing so fast. Because there's so much change so fast, people don't have time to adopt to it. So.
Yeah, you bring up a good point, and actually reminds me of some work I did in California, which they talked about not being able to discharge some children from a children's hospital because they were getting discharged to a home that doesn't have electricity. That, to me, that's a bit of a reality check. We live in a great state of California, or great weather at least. No, a great state. But we have people literally in the state that don't have electricity. So when you talk about phones too, there's people that don't have internet or might not have a smart device. So it's just a little bit to think about, yes. And it's actually been exciting to see in parts of Medicaid or Medi-Cal and parts of even the senior population in Medicare, they have these programs going on where they actually are outfitting older people and indigent and poor people with like iPad type devices to keep in their home just in case they need to visit a doctor. So we're trying to bridge that gap. They're trying to bridge some of those barriers, but yeah, it is a real barrier that not just getting a person to be able to run a phone and like maybe having an older person maybe text message, that can be hard, but they're putting these devices in homes to help people get care.
Got it. Okay, cool.
Well, I'll maybe pick up the pace a little bit so you guys we'll get through a few more of these slides, but this one right here is actually showing exactly what we were just talking about. The blue section is elective care. And this is, you can see January, February, elective care was running. You can kind of ignore dollar amounts, these are just overall claim dollars, but was running at a good point. You can see March, that's when COVID really hit. April got even lower. There still was some elective care happening, but not very much. And in some parts of the country, these went to zero. And then you can see it kind of creeping back up. And by the end of the year, in this projection, we're saying that elective care will probably be pretty close back to where it was at the beginning of the year. Orange required care, if I lined up all these orange bars, they're probably pretty darn equal to each other. They just moved because the blue moved at the bottom. But what you can see is this gray care. This is COVID or coronavirus care. We had some in February, more in March, even more in April. May was a lot. June seemed to kind of, I think a lot of people kind of thought Corona went away. We're now into mid-July, and I'm predicting July is going to be a big month. Maybe you can look at this graph and maybe I'm being too favorable and thinking Corona is going away faster. But you can see elective are coming up and Corona is going down. But you can kind of see how this line across the top of all these bars didn't change that much. But a lot of elective care was replaced with Corona care. Some even required care declined to keep the overall cost very similar. So this is kind of talking about that shift between elective, required, and Corona care. Right here is another way of looking at that same thing. Portion of 2020 spend. You look at the left circle, it says 12% that's going to be coronavirus. 16% is going to be elective, and about 72% required. You go over to the right circle, that's more of an average across the board, is where 3/4 of the care is required and 25% might be elective. Notice those two pies are very similar, but one is filled with gray and blue, and one is just blue. So that's where where I'm trying to say is the projection of overall cost, kind of like I was saying, maybe 2% is maybe where I would say on average maybe, isn't a huge change, even though we've added a lot of care to the system when it comes to Corona.
Got it. So I guess that's a question, right? Like, you're showing the percentages of the pie, but the question also becomes how different are the sizes of the pies, right? Because, one thing that we've been hearing from carriers, and we've now been communicating to clients as we're hearing about them, are rebates that are coming back. I guess, they're calling them premium credits right now.
Yep.
But, for a lot of, for carriers, they have to follow medical loss ratio rules.
Yep.
And so for a lot of those carriers, they don't have these elective spends, right? The top, two of the top three sources of spending usually in healthcare, right, are musculoskeletal and back, expenses. So those kinds of things just aren't happening right now. So as those aren't happening, carriers are sitting on more cash. They're spending some on Corona. It's just going to be, overall at the end of the year, what are the sizes of these pies? Do you think that the overall pie is going to be smaller, even if we're including some COVID costs? What are you guys seeing there?
Well, that's kind of where I'm saying is the 2% increase. But the more, and some of these projections, I'm being pretty, I guess, how to say it? Like, I guess there's a good chance there could be more. It could be more positive than I'm even showing. I want to show positive news. Yeah, I have a client that is just doing a half month of premium credit back to all their members across their whole population. I've heard of even bigger numbers than that. There's rebates going back. Yeah, there's rules on what they have to spend. Like loss ratio rules. And I just when that first number came out in February, March, saying 40%. And now we're hearing about premium rebates. That's good news to us all. And if I was today really to tell you what I think, the on average said 2%, but I really believe that we're probably closer to my favorable number of a negative increase, or at a minimum staying flat from 20 to 2021.
Got it. Okay.
So this next one, we'll kind of look at this real quick. This on the left side, this kind of talks about the different care. And what I'm saying is inpatient care has actually we're spending more on inpatient care. But we're spending about 10% less than we would think on outpatient care. And professional care is down about 15%. And pharmacy really isn't changing much. A majority of pharmacy spend already was for people that are on drugs that they need all the time, and they're still getting them, be it via the mail, be it they're going to the pharmacies. But part of it equals out to 102%. But what I'm saying is inpatient care is getting more expensive. The average acuity is higher, more is being spent, but a lot of it is being offset by less outpatient and less professional claims occurring. So this is all based on the average assumption. That was my middle one earlier on the 3 bars. But the dynamics of outpatient and professional helping offset any increased inpatient costs, and I guess really required costs, and this does include COVID in this, it does ring true that those other places of service are helping offset some of the additional corona and inpatient costs.
Got it. Now, Josh, for that, so that's showing the percentage changes within their own subsectors. If you broke those out from a dollar standpoint, so, they're not going to be each representing 25% of total spend, right? It could be that inpatients usually, 35%, outpatients a little bit less than that of total healthcare spending.
Yeah.
What would you say is usually if you just broke out total spending across those four categories, which percentage do they each represent?
That's a good question, and it varies a lot by market. If we're talking about like a senior population, obviously you're sicker, the pie is bigger, there's more intense inpatient care. But in a healthy system, I would, and let's just ignore RX for now, I would just call it can be very close to 1/3, 1/3, 1/3. It can be like that, and keep in mind, professional care happens in the inpatient and outpatient settings because you have specialists that are in the inpatient as well. But I've sometimes seen it said, a lot of it depends on the market, how efficient we're doing. We live in California, one of the more efficient healthcare markets in the nation. We have a shorter length of stay than a lot of places, and we have a lot of people, but we have accepted what we call managed care out here, where you get told a little bit more what you should do, when you should do it, and that's a positive thing. I have a client in Pittsburgh or out on the East Coast, I've been in lots of places, where you bring up managed care and they're like, oh, that's a California thing. That's a West Coast thing. We don't do that out here. They do fee-for-service medicine. And I'm going to go off on a little tangent here, but it's something for you guys to think about. There's very few things in the world or in economics in general where supply and demand doesn't really ring true. And healthcare is kind of one of those where in supply and demand, normally when you have less supply, it costs more. But sometimes in healthcare, people will create more supply because they know that people are getting paid well to do it. So in other words, doctors can often create supply and essentially create demand. They can refer to those things, but it's a little bit backwards in the fact of sometimes when you have more supply, it actually leads to more costs happening. We had a client up in the state of Washington where they saw a huge influx of specialist doctors to one region. And you would think that, oh man, they all got more competitive, their prices came down. No, what it did is actually just more people went to see a specialist because there were more specialists, and it actually drove up the cost in general. So a bit of, in healthcare, there is a bit of I guess I always say misaligned incentives where a lot of times doctors, and I'm not trying to just bag on doctors, it's not a doctor problem always, but doctors make more by doing more. People often feel better by getting more. So in the end, but efficient healthcare doesn't always mean more is better. Efficient healthcare is getting the right thing at the right time by the right person. So it's not always more care is better. And that's one thing in our system where a lot of the waste comes from is people want more, not always right. So.
Got it.
Well, I'm going to kind of jump here to some common questions I've been asked over the last few months. And some of these questions were earlier on in COVID, but I think it should hopefully answer some of the questions you guys might be thinking. But what is herd immunity and why does it matter? I don't know if you guys have heard of herd immunity, but that's one big thing they're talking about is until we get herd immunity, until enough people have had COVID and or have a vaccine for COVID, it's going to keep on spreading crazy. And that is true. And they say until we probably have 60% of our population either with a vaccine or have had COVID, it's going to keep on probably growing because it all becomes down to a math number. But like if a person has it and they can potentially affect 5 people with it, if 3 of those people have already had it, they're less likely to catch it and less likely to pass it to the next person. So we need to get to a point of herd immunity where enough people have been exposed to it or vaccinated that we are all protected. That's why we get a flu shot every year, is you're helping to increase the herd immunity of our herd, of the US, of our populations. And you start seeing it in some sectors where people might not vaccinate, and I don't want to go down any of these crazy ones that could get too political, but like you can start ruining the herd immunity by avoiding getting either a vaccination or something, and you end up hurting not just you hurt the whole population. So that's herd immunity is really important, and that's why maybe opening up our doors and loosening up the lockdowns, we are going to see more cases, but hopefully that's helping our herd immunity. Is there a lot of pent-up demand, and will it affect 2020 and 2021? There is pent-up demand. There are people that didn't get knee surgeries, shoulder surgeries, heart surgeries, didn't go see their specialist, didn't go get their teeth cleaned. That, yes, will probably increase later in this year and into next year. And that's part of the reason I'm saying maybe we will still see some increase in our rate increases coming from from the insurers next year, is because they're trying to account for all the care that didn't happen this year. They might give you a credit back on some of your premiums, but with inflation and with just increasing costs, and with what they might be saying is pent-up demand, there is a chance that that pushes towards rate increases being a little bit higher. What is the effect of telehealth? We talked about it earlier, but a lot more visits are happening virtually. They are a lower cost visit. I guess we've seen a move in business in general where a lot of people are able to work at home now. I think in the same way, we might see a lot more doctors. There might be doctors that never see a patient in person anymore. Telehealth I think is going to be with us, and it's going to stick. Why are ER so empty? I think that was a fear thing in the past. And some of it is, I think truthfully, a lot of it came down to a fear, but some of it came down to people are thinking twice before they consume care and where they consume it. And I think there are good parts about ERs being a little less busy. When do you think the economy will open, and should it open? Well, the economy opened, and I think we're tightening it back down now. But I also believe, and I think all of us here, every business is affected, and it's been hard. I'm at a small business, and it's been hard. I've seen big businesses, and it's been hard. I do believe that in the end, yes, there's this balancing act. We see it on the news all the time of, are people's lives more important, or is the economy more important? Because those could affect you both ways, like not having a job, mental health, people dying of the virus. Some people say all this is a flu virus. I don't believe that at all. But at the same time, I do believe we need to stay open to the point. I don't think we should go back to a full lockdown again. I think that might just be delaying too much. We were trying to avoid the surge. And this is what I'll talk about real quick here is the surge. At one point, it looked like we were going to need 10 times the amount of beds that we even have in a hospital. We avoided that surge. Yeah, we're seeing some surging come up now and hospitals getting more full, but it's a lot more bearable than where it was. One question that's not on here that I want to make sure I touch on is everybody's talking daily about case counts. We had 60,000 cases today, or we had 50,000 yesterday, or whatever it is. Case counts are important, but you have to remember more people are being tested today than ever before. So cases are going to go up. If I was you, and when I read the paper, when I look at the Orange County Register or the Inland Empire newspaper or whatever, I look at hospitalizations, I look at ICUs, and I look at deaths. Because those are really showing you how many of the people, how is it really getting that much worse? In a lot of areas, we've actually seen hospitalizations going down. We've seen some where deaths. In my town, 2 months ago, we had 9 deaths in the city I live in. I looked at the death count yesterday for COVID, and we have 10. So in that 2-month time, we've had 1 more death. We have had quite a few more cases. We have had people go to the hospital and recover, but we're not seeing, like, when you see these numbers of cases going up exponentially, there is a piece of that is a lot of it's to do with testing. I was on the phone with a doctor yesterday, actually our medical director at our company, and he was telling me that it looks like the virus is getting more contagious. And he says, but that's not necessarily a bad thing because we're actually seeing the severity be lower. So when we're talking about herd immunity, it might not be a bad thing that the contagion gets a little worse, like it's a little maybe easier to catch it, but people aren't getting as sick, aren't ending up in the ICU as much, aren't ending up in the hospital, because we will help get more people that are essentially vaccinated or have the antibodies. Will claims costs be affected by having so many people laid off? That's a great question. Companies are affected by layoffs. There are a lot of people that are getting unemployment, and I feel horrible about the whole situation there. I don't know how that's going to affect claims, because when you get they might then go on Medicaid, so their claims are still going to occur. It's just maybe under a different venue. What can we do to mitigate the rising costs of healthcare and of insurance and of this COVID virus? Is we can all do our part, be smart. I tell my kids all the time, let's just be smart. Yeah, do we like wearing a mask? No, but we know, even if there is some debate on how effective it is, that it is helping. So let's all do our part to hopefully slow it down and be smart with who we're interacting with. The final one is,
Josh, to that question,
yeah.
I'm sorry to interrupt, Josh. So that question, how to mitigate the rising cost of health insurance. So, for us as benefits consultants, if we're going to groups, or, maybe there's a group representative on the phone here who's going to be, being presented their renewal soon, how exactly should they square the seemingly opposed concepts that they're going to both be receiving a premium credit due to really low claims utilization with receiving a possibly standard or higher renewal increase for next year? How do you necessarily square those two?
That's a good question. And truthfully, I really do think we're going to see very low rate increases. I don't think that we're going to see the big ones, like even nearing double digits or 8, 9, 10% that we've seen in previous years. And I think they are going to be really low. But it is hard because, like we got a credit. Our experience in the past looked like this last year was really good. Why are we getting an increase? When premium rates are set, oftentimes they're looking at multiple years of data, and they're looking at it on average. And they're trying to guess what the average will be in the future. If we use coronavirus this year, 2020, as our average, if our claims cost is really low, that might not be a good average to be projecting on for next year. So that's one thing to be thinking about is, yes, they could, oh man, we did really great in 2020. That doesn't mean that, hopefully, all of us hope that Corona won't be around in 2021 much. So maybe claims will get back to normal. Doctors still and hospitals probably are raising their prices. So there still is some inflation going on. And so just keep in mind that projecting of claims isn't always on your most recent year. It's on multiple years. And even this year is such an anomaly probably that they're going to account for Corona, and they're going to be pricing you on an average expected utilization in this next year. It's not based on, oh, this is what you spent last year, we're going to charge you 5% more.
Got it. So you're going to have to handicap 2020 essentially when you're averaging those rates out.
Definitely. I've been involved in rate development for multiple places, multiple states, looking at that. And we're looking at it, and we have to remember that there's a thing in healthcare called seasonality, where more claims happen in certain times of the year, less in other times of the year. There's even sometimes year over year, you can see patterns, but I don't believe the seasonality and the patterns from 2020 are the new normal. I don't believe that the portion of claims that are going to be required versus elective, that's not going to be going on into the future, because we are going to get back to normal, and we are going to, it's going to be, we will be, at some point we'll be back to, I guess, healthcare as normal. But if I was to say, and I cross my fingers because I haven't, we're starting to see rate increases come in, and groups are probably starting to see some projected what they're looking like. I expect rate increases to be very small this year, because insurers are in a favorable position right now where they haven't been paying out as many claims. A lot of them, not all of them, some of them have not been paying out as many claims. But I would expect rate increases to be lower. I guess that's all I'll say for that. So here we go. Start planning now. I saw this quote on another webinar I was on. I stole it from somebody. Thank you, John. You know you are if you ever see this video. But never let a good crisis go to waste. That was Rahm Emanuel. Coronavirus is a crisis. Country shut down, people lose jobs, this, that, and the other. It is a good time, as even a self-employed business owner, where you start reassessing your business and your thoughts and everything. So I encourage everybody as your brokers, as you're working with these companies, is everybody needs to take a fresh look at what things look like, what things are costing, and just take this time to really assess what you're doing. Don't wait until you receive your renewal to begin preparing for 2021. So some of those things I was saying is hopefully, I guess, be ready. You might even be ready with an actuary or with somebody else that really understands pricing, because if your insurer comes back and gives you a huge rate increase, be ready to ask them questions. Well, why are we getting a rate increase? What were our loss ratios last year? Why are we suddenly this, that, and the other? Start thinking of some of your strategies. Start thinking of who you can help, might get help from, what these conversations could look like, and just start preparing. I would say when I did this presentation many months ago, I might have been saying prepare for bigger increases. But maybe I really don't believe that now, and we'll see how the rest of the year plays out. We're halfway through the year as of about a week ago. So, but just don't keep on pushing it away because you don't want to think about it, but start thinking about it and be ready to have those conversations. I'd say educate your employees early and often about I guess healthcare. Like if you're working with an employer, like let them know that like what you're seeing or what we're hearing. Like I think a big problem in the healthcare system is education of members, of administrators, of doctors, of everybody. I think there's a lot of people that just need to understand the system more on how to use it. Some final thoughts. Oh, John, did you have a question?
We've got some questions, but let's wrap this up, and then we'll go over some questions and a couple final thoughts after this, okay?
Perfect. Well, I guess I'll just sum it up by this saying, there is light at the end of the rainbow. There is hope, and we're going to get through this. There's times in this where we feel like we've been in a sprint, and we need to start transferring into a marathon. It's going to take some time to get back to the new normal, but be patient with, I'd say, with doctors, with your employer, with your broker. Maybe brokers, be patient with your employees, or not employees, your clients, because we all got put into a sprint real fast where we learned how important Zoom meetings are, and now we're in a bit of a marathon to find out what this new normal looks like. But I look forward to maybe answering any questions. At the end, here's my email address. If you have questions, feel free to email me, call me. But we can talk questions now as well. But thanks for having me. Thanks for listening to me. And sorry I talked so much.
Hey, Josh, appreciate it. No, so a couple questions. First one from John Robbins. So with hospitals, right, we're seeing news about some hospitals that are operating in the red, and they're having losses, right, because the money not getting paid out from carriers to hospitals. That's lost revenue for hospitals. So do you think that it's possible that hospitals will try to do things? I mean, they're going to find ways to increase their revenue, right? Even if they're in nonprofits, right? We know hospitals are business. They're in the business of making money. Do you think that we're going to see any provider fee increases or other things that are going to increase claims costs to providers?
I do believe we will. In general, yeah, like you're talking about hospitals being in the red. We have seen, actually, there's a thing called the charge master at a hospital that lays out prices for everything from a Q-tip to a surgery and all these different things. We have seen charge masters, like some hospitals starting to adjust charge masters up. We've also seen some actually very collaborative relationships between insurers and hospitals where insurers are even prepaying for some care to help hospitals get through these hard times. That's been good to see. Because oftentimes you have an insurer on one side, you have a hospital on the other, and they want to do this all the time. But you're starting to see some of this, where they're coming together and making sure that they know they both can't survive without each other. So there has been some favorable, like even sharing of monies and in contracting. In the end, a hospital can raise their charge master, their menu prices, but in the end, insurers negotiate what percentage of the menu they pay. So hopefully in the end, the numbers aren't drastically different, but you are hearing about it, and some of it comes back to a business too. Like if they're not able to see as many people, some things should cost a little bit more, and sometimes they will.
I guess, Josh, one thing we didn't really talk about was prescription spending. So, we talked a lot about inpatient, outpatient, ER visits and all those things. There looked like a very marginal difference on pharmacy spends from your projections. I think it was like literally 0.5% above trend, above expected. What anticipations do you have for 2021 moving forward?
That, I guess the biggest unknown right now is a vaccine and how much it's really going to cost. And is it something that the government just pays for everybody to get vaccinated, or is this going to be something that insurers will all pay for, or we have to pay for? But historically speaking, a few years ago, we saw RX trends in the teens, 15% high, really high RX trends. We saw there's drugs, Sovaldi, and some of these drugs where it's $100,000 a dose. And we saw these drugs. There are still very expensive drugs out there, but we are actually seeing RX trends very similar to like medical trends right now, where they actually are lower. And I think they're not going as crazy as they used to. So when I'm pricing like for a self-insured group, like I think right now, an overall trend, RX and medical included, if you're using an overall trend, somewhere in that 6% to somewhere in that range is probably pretty legitimate, 6 to 8%, somewhere in there. And that's across medical and RX. It might, that's probably a pretty safe medical spend or trend. I've seen it lower, I've seen higher, but RX trends I don't think are in a spot right now where they are going crazy. But there is this big asterisk on that comment because of potentially 300 million US people needing a vaccine.
Right. Well, and the specialty drugs have been an issue for a number of years now for driving up the cost of prescriptions. One thing I was wondering if we were going to end up seeing is that you have a lot of medications that are maybe being administered in an inpatient or outpatient facility. Maybe because of this, they're going to start to be administered at home, right? So does that inpatient or outpatient claim become a RX claim, right? Those kinds of like shiftings essentially where care doesn't disappear, it just moves, we're paying from left pocket instead of our right pocket. Is there any potential for that where the delivery of care changes and that changes where we're not missing a claim, but it's just getting reallocated?
Yes, and I think that's like in a very efficient market, like things move from the inpatient setting to an outpatient setting because it's most often cheaper to do things in an outpatient setting. We're now even seeing, outpatient towards home. Like there's even stories of dialysis being able to be done at home now, or there's stories of I saw a thing a while back about moms being able to use an iPhone to put the camera up to their kid's ear and see if they have an ear infection. Like there's stuff being developed that's totally outside the box. And I think that part of that, even with drugs, like IV administered drugs, more and more of those being administered at home, that could end up driving down not only inpatient, outpatient costs, but even RX costs as new venues and new technologies allow. Yeah. Right.
And then I think last question I'll ask, because this is just something I really wanted to touch on. You mentioned getting the right care at the right time to the right person. We're seeing obviously this huge adoption with telehealth, right? It's the most massive adoption of telehealth that's ever occurred, right? We've been talking about it for a few years, but this has really forced it upon us.
Yep.
Do you see, or have you heard from any plans or any insurers yet that they're going to start making incentive changes, right? So changing of plan design to incentivize certain behaviors that maybe people are more familiar and comfortable with now than they were, even just 6 months ago. Do you think that there's going to be any significant changes in plan design to incentivize certain behaviors?
100%. I think we call it value-based benefit design, but there'll be incentives to probably do telehealth over going to an office. There is incentives. Yeah, we're already seeing it in the market. And I think if you have self-insured groups, if there's people on here that work with self-insured groups, and I think part of your plan design should be to incentivize some of that, should be to incentivize, I know historically there's a word called wellness programs that everybody talked about, but nobody could ever measure if they did anything. And that is still kind of true, but pushing people towards health and wellness. And a lot of people don't go in and get their physical every year because they don't want to just deal with going to a doctor's office. Yes, you can't do all your physical stuff over telehealth, but you can actually do a majority of it. Even having a conversation of a doctor asking you, are you sleeping well? Or do you have pain? Do you have this, that, and the other? all that is preventative care that I would love to see a majority of it all done via telehealth, because I think the adoption rate or the actual percentage of people getting these visits should skyrocket, and that shouldn't make our costs skyrocket. In the end, if we do that, we should be able to catch a lot of things earlier and costs should be going down. So I 100% believe that everybody from large insurers to self-insured groups, I think need to embrace it, and I think it actually will save people money. I'm working with a couple startup companies where they're making apps for telehealth for specific conditions. It might be, I mean, I guess I probably shouldn't even say what conditions they are now, but like there's a lot of apps being developed for a lot of conditions where people would normally go see a doctor, but they have this app, it asks some questions, how you feeling, doing this, that, and the other, and you can do a visit with a doctor for conditions right on your phone, which is great.
Wow. Yeah. I mean, because that was, we'll have to, I'm planning on trying to do something like this again in a month or two so we can have a little bit of an update, because there were a few areas we didn't touch on. I'd wanted to ask about mental health, but the other is that chronic disease management. Yeah. Because, a diabetic who, there's already always questions around how to get diabetics more compliant with their treatment plans. Has that been falling off because of this? Well, what are ways to do that from a telehealth visit or telemedicine aspect? So, yeah, well, Josh, I think that's kind of everything that we've got. We're a little bit past the hour, so I want to get everyone on their way. So we're going to get this uploaded and available to everyone so you can rewatch it. And Josh, we can also make the presentation slides available to everyone as well, correct?
Yes, I'll email them to you right after this. And thank you so much for having me. And it's been great.
Yeah, thank you, Josh. And thank you, everyone, for attending. We'll be in touch. I'll send an email out with all this information and resources available. But shoot us an email or follow up with us if you have any questions. Have a great day.
Thank you.